We decided to have a fun, entertaining talk, informative and so on, after lunch. And I asked Kazi if he would be willing to play that role, and after much persuading, he agreed. Kazi is a cardiologist. By the way, it's Dhruv Kazi, but he goes universally by Kazi.
Except my parents.
Except his parents. I met them, and they were a little baffled when I referred to him as Kazi, since, of course, they're Kazi also. Kazi is a cardiologist and health economist and an outcomes researcher. He has trained in so many places that I don't have time to tell you, but many continents and many cities within this country, and arrived happily for all of us at UCSF 5 years ago, and the Colloquium's 5 years old. Well, that's a coincidence. Not. Really is a pleasure to introduce Kazi to talk about some of the myths and facts about modeling cardiovascular disease prevention. Kazi.
I'm going to start with a picture. This is what's called a tree map. It's from the Institute of Health Metrics and Evaluation, and it's one way of depicting the total burden of disease in any given country. So the surface area occupied by a disease is the proportion of the total mortality contributed by that disease to the nation's health. And as you can see on the top left corner, so the blues are the non-communicable diseases, the reds are the communicable diseases, and green is injury, trauma, self-harm. And on the top left corner is this large chunk of cardiovascular disease, ischemic heart disease and stroke being big ones, but atrial fibrillation, diabetes-related conditions, etc. Now I present to you two such tree maps representing two different countries, but you can see overall the burden of disease is more or less similar, with fairly large areas of the total disease being cardiovascular disease. But here's the rub. One of these is a large liberal democracy of Canada with a global GDP per capita of $40,000 per person. And the other is Kyrgyzstan, which is the small Central Asian republic, 6 million people, the GDP per capita 1/40th that of Canada. And for a second, you might have trouble telling which one is which. And that is the point of this exercise, which is that these two countries, which share almost nothing in terms of geography, history, culture, diet, political systems, health systems, have this very common experience of cardiovascular disease in their populations. Which brings me to the statement, cardiovascular disease is a shared human experience today, affecting the rich and the poor. So why is it so hard to make a case for investing in cardiovascular prevention? And over the next 10 minutes, what I hope to do is present to you 5 myths that persist, despite evidence to the contrary, that impede investment in cardiovascular prevention, and how we can turn those around based on evidence. So number 1, cardiovascular disease is a disease of the wealthy, affecting rich countries or rich people in poorer countries. Very pervasive idea. I've started out with the tree maps that show you that's not the case, but let me dive a little deeper. More data from the Institute of Health Metrics and Evaluation at the University of Washington, looking at age standardized death rates from cardiovascular disease. The scale is somewhat hard to read, but the dark blues are the lowest rates of age standardized cardiovascular deaths. As you get to lighter blues, oranges, and reds, that's about a 6-fold increase in the rate of cardiovascular deaths. And if you see, the hot spots are not where we imagine them to be. These are not wealthy countries. Ironically, Australia, Europe, Western Europe, and parts of North America that are wealthy are dark blue. These are countries with the lowest age standardized rates of cardiovascular death, in part because they have fewer events, in part because these events are showing up later in life, but in part because there are functional health systems. So you have a heart attack, you survive it. You don't automatically just die like you would in some of the other countries. And this figure kind of brought it home for me. So this is men on the left, women on the right. The farther you are from the midline, that's the increased burden of cardiovascular disease. This is all cardiovascular disease. The countries are lined up on the x-axis, from poor countries at the bottom, rich countries at the top. And you can see clearly that cardiovascular disease is not a disease of rich countries. It is the people in the poor and low and middle income countries that are dying of cardiovascular disease. All right, so I get that, but is cardiovascular a disease of rich people? That was among countries, but what about within countries? Does it affect rich people? And so here's data from Dr. Bipin Semengo and Joanne Penko showing that when you look at 8 standardized event rates for cardiovascular events in the US, high SES compared with low SES, defined by income and education, there's a clear excess mortality in low SES. This is related both to the burden of the disease, health systems related differences, but there's something about the social determinants of health itself that explains a big chunk of this discrepancy in outcomes. In wealthy countries, cardiovascular disease today disproportionately affects low SES individuals. But how about in poorer countries or low and middle income countries? Now here's data from India. When we look at the prevalence of hypertension in urban Indian women, and on the x-axis, on the y-axis is age. So younger women at the bottom, older women at the top. You can see there's a clear age gradient. As we get older, the prevalence of hypertension goes up. I want you to pay attention to the numbers. By the time you're over 65, we're talking about prevalence of hypertension in the 50% range. These numbers are mind-boggling. But on the x-axis are quintiles of household wealth, going from poorer on the left to wealthier on the right. And if you look on any given age band, there really isn't much of a gradient by quintiles of wealth, saying that if for a woman living in urban India today, whether you're in a poorer household or a richer household doesn't seem to materially affect your risk of hypertension. I could reproduce these data for diabetes, rural versus urban, men or women. The essential point is that the idea that this disease is a disease of wealthy people doesn't hold up in these data. But this is risk factors. Conditional on the risk factors, once you develop the disease, in fact, the low SES individuals do much poorer because of health system related factors where they don't have access to care. So tying together the higher burden of disease in low SES individuals and in low development countries, we come to this fact that CV disease, in fact, disproportionately affects low and middle income countries, and within countries, often disproportionately affects low SES individuals. So the heart disease is not a disease of the rich. Myth number 2. By the time a country develops cardiovascular disease, it should be able to invest its own money in prevention and treatment, right? And I argue that this is the legacy of the theory of epidemiologic transitions. We all started poor with the plague, then we had pandemics like cholera, then we got wealthier, we got heart disease, we got even wealthier, we got Alzheimer's, which kind of describes the experience in Europe and in wealthy parts of North America, where economic progress happened over a century. But I don't need to convince this audience that this is absurdly simplistic for the experience of low and middle income countries today. So it is possible for Uganda to have to figure out the HIV epidemic and also figure out what to do with 25% of the population that has hypertension. It is possible today for a country to need to figure out how to deal with an Ebola epidemic and manage diabetes. That is the truth in our world today. However, donors don't always follow that, and this is one of my favorite graphs from Rajay Bhatnaji and others at Stanford, and appropriately called Misfinancing Global Health. On the y-axis, it's the amount of money spent by the 4 big donors on global health, and on the x-axis is the disability-adjusted life years, right? And so where we want to be is here. We want to say that the diseases that cause the most disability-adjusted life years are where we spend the most money. And that's just not the case. If you look at non-communicable diseases, huge burden of DALYs, and yet almost no investment in terms of aid money going to NCDs. This is 2008 data. IHME now has 2016 data that look shockingly similar. 2% of the money going to non-communicable diseases. It's related to that perception that by the time you have non-communicable diseases, you're wealthy enough to deal with it. So LMICs already face a disproportionate burden of CV disease and are underfunded to combat them. Donor apathy costs lives. Okay? Myth number 3. Well, prevention only makes economic sense if it's cost-saving, right? because a stitch in time saves 9. Prevention is always supposed to save money. So here's where I'm going to talk to you about the popular narrative versus reality about prevention. Now, hold on here, hang in here with me. So imagine a person in some unidentified country with some costs on the y-axis of cardiovascular care. They're chugging along, they're doing well, they have that first heart attack and they have a huge expense, then the costs of care go up, and then they have a second heart attack, another huge expense, and then they die. This is the popular narrative of cardiovascular costs. And so the idea is that if you invest in prevention up front and you prevent all those heart attacks, wow, there's so much money to be saved in terms of the events that you've prevented. Now here's what actually happens. In reality, mean costs on cardiovascular care are kind of stable, and they chug along, and they're low for 2 reasons. In high-income countries, mean costs, per person costs are low because we're having fewer and fewer events. So the highest risk subgroup in the US would be people who've had a heart attack in the past. It's showing that you have the disease, you might have another heart attack in the future. And even in that setting, the event rate is about 3%. So 3 people in 100 will have an event a year. So population averages of healthcare costs are lower. In low and middle income countries where costs are actually higher, where event rates are actually higher, what's happening is people are having the heart attacks, but there's nowhere to get treatment. And I'm going to say this as empathetically as I can, but death is cheap. And so these guys essentially are having these young individuals having heart attacks just die, and there are no healthcare costs to be had. And so if you just look at healthcare costs, this is what it looks like. Mean costs are low, and when you overlay prevention, there are not savings to be had. But what you are getting is that people are living longer, healthier lives. And that is the economics of cardiovascular prevention. It's not always cost saving, but it is a very efficient way to buy good health, particularly when we compare them to therapeutic options. And then if you go away from the healthcare costs and look at societal costs, the picture changes. And we talked about this a little bit with Kirsten's talk earlier, which is if the 45-year-old in India who's dying of a heart attack, if you include the lost productivity because the person died early, or if they survived the heart attack because someone in the family now has to, often a daughter or daughter-in-law has to stay at home and help that person, if you roll in the productivity losses as substantially higher than healthcare costs, now prevention can save money, because you're taking into account all of the costs that you've averted. And these are real, it's just that in a fragmented system, these costs are often invisible. So which brings me to fact number 3. Commonly used strategies for cardiovascular prevention are cost-effective, a good way to buy health, but may not be cost-saving unless we consider productivity losses. But here's the rub. Cost saving is not a bar we apply to therapies. We don't say, I'm going to treat your cancer because it's going to save money, or I'm going to treat your heart attack because it saves money. And yet we hold prevention to a higher bar. And as you'll hear later in the afternoon from Margot's talk on housing interventions, this is an unfair bar, and we should be willing to spend the same amount of money to buy health, whether it comes from prevention or treatment. All right, myth number 4. Investing in cardiovascular prevention is economically unattractive because returns are delayed, right? So you invest in the health of adolescents and then you see improvements later in life. Now, why is this a problem? In cost-effectiveness analyses, we typically use a process called discounting, which means that costs and benefits that accrue today are weighted more than those that arrive in the future. And so you can see if your benefits or savings arrive many, many years in the future, you've discounted them so much, it's hard to prove cost-effectiveness and certainly cost-saving. The other aspect of why this delay is problematic is the tyranny of the political cycle. So in countries where politicians are answerable to their constituents, a problem that you and I don't know very well these days, there's a problem because politicians have to say, you know, I did this for you, I built this hospital, and look how amazing the shiny structure is. That's easy to invest in. Whereas when you say, you know, I built this program that gives you statins, and you're not going to have heart attacks in 10 years from now, that's a much harder sell. So the tyranny of the political cycle is real. I submit to you, however, that this idea that the returns on investment on cardiovascular prevention are delayed come from this perception of we're looking at one person at a time. You're treating one adolescent and seeing what happens to them, one young person and seeing what happens to them later in life. When we look at it from a population perspective, these returns can show up pretty early. So this is the effect of smoke-free policies and the community risk of acute heart attacks at 12 months. So you institute this policy that you can't smoke at bars, you can't smoke at restaurants, you can't can't smoke at work. And within 12 months, these diverse settings, work from Stan Glantz and Jim Lightwood here at UCSF, showing that the effect is almost immediate. Within a year, you've seen a 15% community risk reduction in heart attacks. That continues to accrue. It's about a third by 3 years. Meaning that if we look carefully and are thoughtful about how to measure effect size, community effects, community payback can show up pretty early from investments in cardiovascular prevention. What I'm pushing you to do from all of these examples is to think separately about individual risk and population risk, because they behave differently when it comes to a prevalent condition. Fact number 4, community level returns are in fact show up early and can accrue over time. So the last myth I'm going to talk to you about is because CV risk reflects personal choices, we should change one person's behavior at a time. Now, I know I'll get a chuckle out of this, but it turns out both parts of the statement are untrue. It's, yes, I make the decision to smoke or I make the decision to eat McDonald's, but my decisions are in the context of what is available to me, what society has decided to subsidize or otherwise. And at the same time, as much as I know that high school kids in the mission drink a lot of soda, if I try and change one high school kid's behavior at a time, I'm never going to achieve any meaningful impact. And so we do have to think about policy changes that affect behavior at a larger scale. There might be price signals. You know, if you change the price of soda through taxation, it turns out people drink less soda. It's been most spectacularly shown in tobacco, and it works particularly in vulnerable populations that may have higher baseline consumptions, maybe more price sensitive, so when the price goes up, the drop is larger. There are non-price signals. We can talk about regulation or collaboration. Menos Sal Más Vida is the Argentinian effort to reduce salt in the diet at a large population level. Again, yes, we need to help hypertensives reduce their blood pressure one at a time, but at the same time, we are going to have to invest in community-level initiatives. And of course, the best known work in this space is Richard Thaler's book called Nudge. If you haven't read it, I'd recommend it. He won the 2017 Nobel Prize in Economics for his contribution to exactly this, that people respond to incentives. So the fact is, even though there is a behavioral component, the choice architecture matters, and it's often easier to manipulate behavior at scale. I'm going to end with a bonus myth. CV prevention is most cost-effective when tailored to individual risk. And, you know, this is like, well, should we reduce the blood pressure to 130 or 120? Should we get that LDL from 100 to 70? And this is where I get a lot of flack from my cardiology friends. I'm like, guys, this is like trying to pick the color of the drapes when the house is on fire. Like a third of the population is not taking their statins. Can we stop talking about these expensive cholesterol agents? We're missing the point here. And the idea, again, we talked about this a little earlier in Kirsten's talk, was that even though individual risk matters, if we target our strategies to population risk, we will get farther and we can get there quickly, particularly where health systems are not up to speed. So I'll close there saying that there is a strong case of economic case for investing in cardiovascular prevention, but we have to be thoughtful about this. This disease is not a disease of rich countries or of rich people. Recognize that LMICs lack resources, both money and human resources, to deal with this. CV prevention can be cost-effective, even cost-saving, if we consider productivity losses. Returns show up early at a population level, if not at an individual level. Policy nudges can help alter population behavior, and I think that's where a lot of the money lies as far as we're concerned in cardiology. And these strategies can save lives. So I'll stop there. Thank you. I think we're almost out of time, but I can take one or two questions if there are any.
We went a little quickly, but I thought on that cardiovascular mortality graph when you were comparing the poor and the wealthier countries, that in the wealthier countries, men were more likely to die at the older ages, and in the poor countries, that was the reverse, that women were more likely to die.
I think in general, if you do not correct for age, then women die later, because the disease shows up later.
But it looks like
for any given age point, the mortality in women is often higher, and we think it's related to access to care, which is that even in the US, if you show up into the emergency room and say, I have this vague chest discomfort, and you're a middle-aged man, you will get the full cardiac workup, and the middle-aged woman coming with the exact same complaints will be like, it's just heartburn, get over it. Thank you.